So good afternoon. I was joking with Ed. I said, thanks for giving me the slot. After Dr. Hibashi, who always wows everybody with his stuff, and now you've got a full belly and you're ready for a nap. So I guess I'm the lullaby person to put you to sleep, or hopefully at least keep you awake. So I'm going to talk about lung recruitment. I chose to sort of break it down into going into techniques and then monitoring. So what techniques can we use, and how do we monitor it? And as you heard from Dr. Hibashi, and I'm a proponent of APRV. We use APRV pretty much the way that he uses. I'm sure there's some intricacies that we might not follow to a T, but I think it is the ultimate recruitment mode. So there I can end my lecture there because you've heard about recruitment, but it's not quite that easy. What I think I need to say first, obviously it's sponsored by Draeger, so me being here is sponsored by Draeger, but I really don't have any perceived conflicts of interest. There will be some things mentioned, some devices at the end, and it's really for illustration purposes and sort of to show you some of the technologies that are coming down the pike. So I'm not mentioning them to try and sell them to you. In fact, they're not really for sale yet, but to just show you for purposes of illustration. What am I going to do? I'm going to do sort of a little background review of ARDS, lung recruitment type stuff, so some stuff about ARDS. You've heard a lot about ARDS, about alveoli, and you've seen some things about lung injury and that kind of thing, and I may blow through some of those slides if appropriate, but I want to give you just a little bit of background as we walk into why would we want to lung recruit the patient, and then we'll talk about techniques to lung recruit the patient, as well as then in the second half we're going to move into monitoring, how do we monitor lung recruitment, and then I'll give you some summary and conclusions. So why do we worry about lung recruitment or injury in the first place? Well, ARDSNet, and this is a very difficult to read slide, but this is, if you know ARDSNet, you know that everyone talking about ARDS will mention ARDSNet, that it was the largest study. It was evidence that if you are using volume ventilation, then stretch the lung less with lower plateau pressures, tidal volumes at 6 versus 12 mLs per kilogram is an important thing. So that whole thing is a lecture in and of itself that's outside the scope here. But I say this to say we started worrying about how we ventilate patients because we saw in studies that we can affect how many patients live and die and also quality of life. So just use that as a preface to say in ARDS and ARDS type situations, study like ARDSNet makes us think, hey, we found something we can do better. Is there more that we can do better? Things going back to, and this is 1998, a lot of you have seen this imagery, but you take a rat's lungs that are healthy, you ventilate for 5 minutes, they look fairly the same, a little bit of damage. After only 20 minutes of ventilation, you can cause significant injury. So why do we worry about injuring them? Because when we put people on the ventilator, they're on longer than 20 minutes. And going back to 1998, we see that we can do significant damage to lungs. A few terms that I just want to go through that involve ARDS. The first one's atelect trauma. There's some newer terminology. A lot of people hear volutrauma and barotrauma, and barotrauma is definitely a very dated term. Atelect trauma is specifically, and the reason we're going to get into this because it all revolves around recruitment, is it is that cyclic alveolar expansion where on inspiration the alveoli opens up. You saw great videos of those, so I don't have to show you those, but that's where the alveoli snap open and then they close on exhalation. You get trauma because just like if it's a balloon, the alveoli are little balloons, and if you have to go from all the way collapsed to open, it's a lot more stress and strain on the alveoli. So this creates shear forces, and it distends adjacent alveoli as well as causes physical damage to that alveolus. So atelect trauma is an important thing to know about. This goes back to 1970 in the Journal of Applied Physiology, I believe it is. And what they show, and this cube here is a representation of the fact that you have an alveoli. Now, alveoli are not cubic, but if you do math on if this cube was collapsed and then you have surfaces pulling in all directions, we always talk about if you ventilate with pressures of 30 or less, you hear that over and over again, then it's pretty safe. It shouldn't damage the lungs. Well, if those alveoli are snapping shut, in this case, the representation is the cube. They've done mathematics when you have alveoli at all different angles pulling at 30 centimeters, it can effectively feel like to that one alveolus up to 140 centimeters of water pressure pulling it open, and there's where you get those shear forces from. So when you put all this stuff together, you want to stop this kind of thing from happening. You don't want the lung to be de-recruited and have to snap those alveoli back open. So that's all part of that picture of why do we care about this topic. In this placard here, you see a CAT scan next to sort of a schematic of alveoli. On inspiration, you have a characterization here in this region of 3 different regions of the lung that you see in the CAT scan. The regions are different in different patients as far as how large they are. You have consolidated lung, which we're going to see throughout my lecture here in the A placard. These are collapsed alveoli. You have alveoli that are hyperinflated, like you heard Dr. Abashi and others talk about, and that would be in these regions here, the non-dependent regions. And you have these transitional areas where you've got closed alveoli being pulled open by hyperexpanded alveoli, and that's just being put between these 2 layers. So you've got a lot of forces that can act upon one another and pull alveoli in shapes that they don't want to be pulled in. You've seen some grody things when you ventilate wrong, so I'm going to go past that slide in the interest of time. But I want to also bring in, before we move into some other stuff, the idea of biotrauma. So why do we care about this stuff? All this shear force in the lung causes biotrauma. So atelect trauma causes biotrauma. Biotrauma is that physical damage to the alveolus releases those mediators that you've heard talked about, and that can lead to extra direct tissue damage in the lung, as well as can go out and harm other organs. So you get the release of cytokines, inflammatory mediators, all those markers that damage is starting to take place or is taking place, and they can circulate. So that's another reason why we care about recruiting a patient right and ventilating their lung properly. Very quickly on this placard just shows that, again, back in 1998, we were well aware of ventilator-induced lung injury, and this is an animal experiment where they used PEEP or no PEEP in a sense. I'm going to point out to you when they didn't use PEEP, and this is sort of wrapping that injury concept into why do we care about recruitment, because you're going to hear about PEEP and some other things when it comes to recruitment. So if we look at the bars that are labeled in red, all of these are inflammatory mediators that show that lung damage is starting to take place or is taking place. They can recirculate, they can hurt other organs or hurt the lungs further, and all of the biggest bars on these graphs, you can't see it there, are all the ones they use 0 PEEP on. The rest of the bars where you use some PEEP, the lung injury was spared to some extent. And one other concept before we start talking about techniques that I want to open up, because it's so prevalent in this literature that we're going to go through, is the idea of, is there 2 types of ARDS? If you went back 30 years, well, first of all, they didn't quite start calling it ARDS yet, but they didn't really necessarily think there was 2 types. Then they started seeing some data that said there may be 2 types of ARDS, a primary lung-based ARDS and an extrapulmonary or secondary ARDS. And they may be very different, but the reason I have the question marks is there's a lot of newer data and you'll see a mix, so we'll go back and forth and I'll show you, and really the jury's out, so it's up to you to think about these things, to think, is there really 2 types of ARDS or not? That's kind of out of the scope of this, but I think a lot of the literature we're going to go over deals with this. Is there 2 types of ARDS? There's some newer data that shows that maybe they might not be so different. We're not really sure about that. I think one of the problems, and I think that's, before we go into that, this just is one to give you a feel for that. This article here looked at the morphometric differences in lung lesions in autopsies. So they looked at autopsied patients, and they found if the patient had pulmonary ARDS. And what is pulmonary ARDS? Pulmonary ARDS is usually when they say starts out as a pneumonia or a direct effect on the lung and the lung tissue. Extrapulmonary ARDS, just like the name is, something happened outside. You have ARDS secondary to a traumatic brain injury, to a massive blood transfusion, to any one of the things that can happen to your body that you can go into ARDS that's not related directly to your lungs, but the lungs take a hit, and that's your extrapulmonary ARDS. This looked at autopsies, and they saw that alveolar wall edema in patients who died with primary versus extrapulmonary ARDS, or pulmonary versus extrapulmonary ARDS, looked different. So the alveoli in the people who died looked different when you looked at the people, what cause of ARDS they had. So again, we'll talk a little bit about is there a difference between primary ARDS and extrapulmonary ARDS, because there's a lot of studies that incorporate that into their recruitment strategies. Is mortality higher in pulmonary versus extrapulmonary ARDS? They looked at this. So here's that first slide told you the alveolar edema is different in people who died. The second slide here from a different study in chest, it was 2008 in chest, looked at 34 studies. They had 4,300 patients. They looked at the number of people who had primary ARDS and secondary ARDS or extrapulmonary ARDS, and a little over 2,000 versus a little under 2,000, and they found no difference in mortality of those patients. So this would be one study that would point to people saying, well, there must be a little bit more alike than we thought, because the same amount of people die from it, the same mortality rate. So just wrapping up some of the things that we deal with ARDS and the problems and why we care. Atelectasis is not good. We don't ventilate our patients hoping we get atelectasis. We also don't ventilate our patients hoping that we overdistend their lungs. And that's bad too, because that's going to cause injury. Alveolar collapse on exhalation is not good. We've seen it, we've heard it talked about, and it's just not good. It causes injury. That's that attelect trauma, and that causes biotrauma, which also is not good. So it's a whole cascade. ARDS isn't uniform in the lungs. You've seen CAT scans and chest x-rays, as well as you'll see some during this lecture, and it's not uniform. So one of the problems or the issues is that they're dramatically different. There's some very good lung in patients with ARDS, as well as some very bad lung, and how do you not hurt the good lung, but maybe help the bad lung all at the same time? There is this question of, is there pulmonary versus extrapulmonary ARDS, and that deals with how you're going to recruit the patient. Do you recruit those patients different or not? And how do you recruit them without overdistending? And that's a balance. That's an important balance. Like I said, I really do like APRV. I've scrubbed pretty much all that stuff out of my lecture here about APRV, because I knew you were going to get a dynamic lecture from Dr. Abashi. So one of the things before we go into techniques, this sort of is the intro to techniques, is that I think that regardless of whether you use APRV or whether you use whatever you do use at your institution in the best evidence and knowledge base that you can come up with, I think you should have a strategy, a team strategy. We talked about that. I know someone asked a question, how do you get everyone on board? This is just one that was published in Chest in 2010. Not that it's the best one out there, but it is one. And it was published, Dean Hess had a hand in writing this, as well as Curtis Sessler from, I think, Richmond, Virginia area. And I think it's very logical in that they say you approach patients with ARDS or ALI with ARDSNet guidelines. That's pretty much a standard. I don't know that anyone would say you don't do that. Now, some people say you do more than that, but you at least treat them with ARDSNet guidelines. If they're not doing well and you don't like their PF ratio, you don't like their plateau pressures on those settings, you don't like where their oxygenation's going, that patient needs some sort of an elevation. And here in this criteria they recommend increasing PEEP, doing recruitment maneuvers, and towards the bottom here, I'm going to actually bring up the diagram a little higher here. So this is the next step they're at. You do increased PEEP, recruitment maneuvers, and if they are showing high recruitment potential, then you do some other things. You start considering in this branch down here, APRV, high frequency, and if they're not very recruitable, you may start thinking about ECMO. So the point in showing this is that if you don't at your institution have buy-in with how you strategize for these patients, you should. Now, some of the things that we're going to go through next may be part of that strategy. So you should probably start with ARDSNet if you're volume ventilating places. You start with ARDSNet, but then you probably have to march the patient along as they progress and they show themselves to be an extremely sick patient. So my point with this is some of these tools, if some of them seem neat to you, to take those back if you're either doing them or developing them, I wouldn't suggest just going and trying to willy-nilly do things. I think it's best to basically put it in an algorithm, get buy-in with the physicians. We have an algorithm that our physicians and our therapists are all have buy-in to and know this is kind of the route we're going to go with a patient, and it ramps them up as the patient shows themselves as being sick. So before I start hitting some of the techniques, and I sort of would joke with you, again, back to APRV, you're going to hear a lot from me about PEEP. Well, APRV is PEEP, right? Or CPAP. And you're going to hear a lot from me about sustained inflation to do a recruitment maneuver. Well, APRV, that's pretty much what it is. So as I said, APRV, again, just it is, to me, one of the quintessential ways that you can recruit lungs. But what are some of the other things? And I say this is the stuff that pro-con lectures are made out of. And I joke about this, but we could stand up here and we could debate these things, whether they work, whether they don't work. The bottom line is there's no convincing evidence yet that if you do any one of these things, that you're going to absolutely reduce mortality in patients with all these things. And those are the kinds of things that if you go to ARC Congress, you'll see pro-con lectures. You know, should you do this or shouldn't you do this? And really all these techniques are the stuff that pro-con lectures are made of. So we're going to start talking about PEEP and PEEP titration. And you heard Dr. Abashi and others mention that gosh, PEEP's been around long enough. Why the heck don't we know what to do with it? And I think, quite frankly, we really don't know what to do with it. We think that probably more than 5 in ARDS patients is good, and a lot of experts will tell you 15 or above the lower P flex. But again, we have not proven that is going to reduce mortality in patients. In fact, there's been 2 ARDSNet studies, and the one looked at a lower scheme, one looked at a higher scheme, and in reality, there was no evidence about which one would save lives. So a little bit about PEEP and using PEEP to recruit the lungs. So there's a couple things you can do. You can just turn the PEEP up on patients, and that's sort of the basic way. That's what a lot of people do. A lot of people don't do it in a measured or a logical regressive way. A lot of studies use a very logical way because that's what you have to do when you study things. So a lot of these studies are going to be very rigid in how they use PEEP, and we probably should do more of that at the bedside. We probably should not just tweak the PEEP to make the SAT look better. I'll mention that when we talk about monitoring of lung recruitment, but that's what we do a lot is we see a bad SAT, we tweak the PEEP. You know, should we really just be doing that? I'm not sure there's any evidence that that's going to help the patient. In fact, oxygenation of the patient does not necessarily correlate with how well they will survive or not. Anyway, back to this. In this study here, this is one of these studies that, again, looks at PEEP for lung recruitment, and what it did was it looked at the pulmonary versus extrapulmonary lung disease. So it's looking at pulmonary versus extrapulmonary, and this is one of the first ones where they started saying, is ARDS 2 different syndromes? Is there an extrapulmonary and a pulmonary? So this is the pulmonary. So these are the patients who had more like a pneumonia type thing. They've got consolidation in their lungs, probably less atelectasis, probably more consolidation. That's the nature of that definition of how you find these patients. And as they applied PEEP, they went from 0 up to 15 of PEEP. You see my arrows here. So the respiratory system, sort of the opposite of the compliance. So high elastance is bad because it means your lungs are stiff. What they found is these patients got stiffer as you added PEEP. Their respiratory system got stiffer, and the chest wall stayed the same. There's no difference in chest wall. So as you add PEEP to these patients, now as you take the extrapulmonary patients and you add PEEP from 0 up to 15 stepwise, you see the respiratory system compliance. It says elastance, but think that's the opposite of compliance. Their compliance gets better. Their compliance is they're more compliant. Their lungs are more compliant, and their chest wall actually has a little bit of movement as well in the more compliant range there. So you get a drastically different if you say these are the primary pulmonary ARDS type patients versus the extrapulmonary, and you start adding PEEP to them. This would say that you're not going to make much headway from a recruitment standpoint with the pulmonary patient, the pulmonary ARDS, because their compliance got stiffer, which means you didn't really open up much lung. If their lung got more compliant, it means there's more alveoli open. To refute that, there's another one that looks at pulmonary and extrapulmonary, and they used PEEP, high PEEP versus low PEEP, and they separated out the pulmonary ARDS, the extrapulmonary ARDS, and there's no significant difference in how those patients responded to low PEEP versus high PEEP. Again, a different population, ARDS patients, and they had this population they called mixed or uncertain. And I think it's interesting, too, because what they said in the comments with this study were it's difficult to classify if it's truly pulmonary versus truly extrapulmonary. About a third of the patients you won't really know. Recruitment in pulmonary and extrapulmonary in this study in these patients was similar. There wasn't a different amount of recruitment or response to PEEP. And so they say you shouldn't base PEEP levels on the kind of ARDS you think it is, because you may be wrong and they may have actually respond the same no matter what kind of ARDS they have. A terminology instead of just applying PEEP in those situations, you can do something that is a very rigid thing with something you call decremental PEEP titration. Some do an incremental and a decremental PEEP titration. The focus really has come down to the decremental PEEP piece of it. In other words, you're going to hear me say it's a regimen, a way that you adjust PEEP and you watch things and make sure that the physiologic parameters go in one direction as you titrate PEEP. So what do? You start with high PEEP on the patient. You start with about 24. Most people start in the range of in the mid-20s of PEEP. You reduce your FiO2. So once the patient stabilizes, you reduce your FiO2 till you get your SAT in a range of, say, 92 to 95. Depending on who you read, you'll see different things. And then you reduce the PEEP after that in steps of about 2 centimeters. So basically, if you get your FiO2 down to 50%, because now you've recruited the patient well on 24 PEEP, and then you can get your FiO2 down, and then you start tweaking your PEEP down to find out at what level of PEEP does now the SAT drop. Once it drops, your last level of PEEP is probably your optimal level of PEEP for that patient at that time and the way their lungs are recruited, and that's kind of where you would keep your PEEP at. That's a general sense. There's a lot of different people that have different methodologies. In general, that's how they do decremental PEEP trials. Probably the kind of thing we should do at bedside more than just tweaking the PEEP up. So what have people seen when they've done decremental PEEP trials? This is from Respiratory Care Journal in October of 2006. This, and again, these things are probably not showing up that great here. It looks like not too bad. If you follow these bars are oxygenation. They're P to F ratio, PaO to FiO2 ratio. And you see our baseline PF ratio below 200, and so these are ARDS patients, as we said. And you do a recruitment maneuver. That's another technique we're going to talk about. They mix and match these things. They do a recruitment maneuver, a high inspiratory pressure for about 30 to 40 seconds. Again, we'll get to that. They do a recruitment maneuver, and then after the trial, they did a decremental PEEP trial, and they found that value that they came up with when they titrated the PEEP down, and they said, okay, this is the right PEEP level, maintained the patient out 4 hours with better oxygenation than they started with. So from below 150 PF ratio to approaching 220. So, and that's one of the key things, is that if you do a recruitment maneuver and you don't change the PEEP afterwards, or you do something to oxygenate the patient, and then you don't change something to keep them recruited, that's one of the things that would be probably not so good to do. If you're going to try and recruit them, you also want to try and keep them recruited. So in this case, a decremental PEEP trial after recruitment maneuver really helped to keep the oxygenation level maintained out to at least 4 hours. Prone positioning. I'm going to talk about that in this recruitment lecture. And so prone positioning is a recruitment maneuver. I know a lot of people have heard a lot of different things about prone positioning. Prone positioning redistributes both ventilation and perfusion. So when we first started prone in patients, a lot of people thought, hey, you flip the patient and now the blood goes to the good lung instead of the bad lung. And what they found really is the blood does change direction, so to speak, because of gravity, but not so much so as the ventilation changing. And the ventilation change is basically a recruitment maneuver that happens if the patient is recruitable. So one thing I mentioned here about prone positioning before we go to a couple slides about it is there is a high potential for significant side effects. What are those side effects? Well, when a patient's laying on their stomach, how many people prone patients here routinely? I see a few hands, so it looks like not the majority. How many have ever prone people? How many have ever seen a significant side effect from proning? I see some hands there. So it happens. If the patient needs CPR, how do you do CPR when they're laying on their stomach? if the patient's ET tube comes out, how do you re-intubate them? Or they start bleeding out from an art line that came out and you don't see it until there's a big puddle of blood on the floor because now it's underneath of them, and those kind of things. There's all kinds of significant side effects that you can have. And so usually you don't want to prone the patient until you think you really kind of have to in the sickest patients, because the benefit is outweighed by those potential detrimental effects. But essentially, if you look in this placard, this will show you really how prone positioning is, in fact, a recruitment maneuver. You've got the patient laying in their back. They're laying on their back here, and they've got their heart, and most of these patients' hearts are weighing down, as the arrows show, on this area. And you know from ARDS, this is the location that a lot of the patients have the most dense consolidation, and therefore if the patient is laying here like this, you've got the heart pushing down on that. If you prone this patient, what happens is there is actually less lung tissue sitting under between the heart and the sternum of the patient, but what it does is it not only allows this lung to open, but I've even heard people say, you know, the heart almost, the tissues and stuff can have a pulling effect where it's actually helping to pull that tissue open rather than like to promote recruitment, even more so than just taking the weight off of it. But nonetheless, it's definitely taking the weight off of that lung tissue, and you will get some recruitment from that. So if we look in this, this was a sort of a pro-con lecture that turned into an article, should prone positioning be routinely used? So and I circled two of them. This is a patient who is supine. This is the same slice when they're prone. So if we look here, we've got the heart, and you've got really no interventions except proning. You've got this atelectasis and consolidation here, and you see there that it's opened up more. There still is some there, but you certainly see less consolidation, less atelectasis in that region there, and that's when you flip that patient over. Now you get the added benefit that you do get some changes in the blood flow, but I think the main factor, my opinion is, and from what I've heard people say, is it's probably more of a recruitment maneuver when you prone people than it is that you've dramatically changed their blood flow when you see those dramatic results sometimes. So what do you see? You see the patient's compliance can get better. It could stay the same, because when you're upside down like that, your lung compliance actually would drop. But if it stays the same, it's probably a good sign, because that means that even though you're in a worse position for lung compliance, that something opened up and now your lungs are easier to ventilate. And you also will see increases in oxygenation with this. There are some large studies that have been done with proning, so the people who are big advocates of proning, a little disappointed to say if I apply proning to lots and lots of patients with ARDS, it doesn't reduce mortality. They've done meta-analysis, and I believe that the best summation of what you would say about proning is the sickest quartile of patients will probably benefit from it. So if you apply this to the sickest of sick ARDS patients, you have a chance of changing mortality in the patients, but not if you just apply it to anyone who meets ARDS criteria. Just a couple of things looking at responsive prone. So now I think I have one or two studies here that looks at the extrapulmonary versus the primary pulmonary ARDS and how does proning respond. So in this case, so you would think, if you think about the physiology of extrapulmonary versus pulmonary, if we were saying, okay, if they are two different things, and if extrapulmonary is more atelectasis, is more recruitable, and pulmonary is not, then you might see more dramatic oxygenation effects with proning the patient, because you might have better mechanism for that. So if extrapulmonary, that's my EP here, and we do get a more dramatic increase in oxygenation with extrapulmonary patients than with pulmonary patients. Now the pulmonary patients do make progress more slowly over time, but the extrapulmonary seem to recruit much quicker, if recruitment is what's causing that increase in oxygenation, which is probably a lot of what it is. What you also, let's see, I think that was the main thing I wanted to go over on that one. And if we go to this next one that looks at proning, and this is a small study, I thought it was interesting. This is a Turkish respiratory journal. So I don't know if we have respiratory therapists in Turkey yet. I know Tony's out there, maybe she knows. But if not, we've got a respiratory journal over there who's focusing on respiratory, which was kind of cool, I thought. Anyway, small study, but same kind of thing. And you take the extrapulmonary, and the extrapulmonary, again, does have a more dramatic oxygenation effect than the pulmonary patients. And in fact, the pulmonary patients that are primary pulmonary ARDS did not make too much of a dramatic improvement with proning, whereas the extrapulmonary ones did in this particular study. So that's proning. Proning, very simple. There's that in and of itself would be an extra lecture. So just we're doing sort of a quick tour of some different things you can do to recruit your patients. And the next one I have on the list is recruitment maneuvers, which I've already made reference to, and going to cover a little more in depth now. Recruitment maneuvers typically you would hear people, for a while there it was 30 for 30, and what they meant was a peak airway pressure or a CPAP or whatever you wanted to call it, but it was a sustained pressure with no other breaths of 30 for 30 seconds. And then they started pushing the envelope and saying 40 for 40. So somewhere in the range, a standard value would be 30 to 40 of pressure for 30 to 40 seconds of CPAP, where the patient, certainly you want them to be able to breathe if they are awake and want to breathe. Some people juice them a little with sedation just so they'll tolerate it a little bit better, but then if you give sedation, it might also hurt their cardiac output. One of the things when you put patients at a PEEP to 30 or 40 or higher for a half a minute or more is that you can see hemodynamic compromise. That's quickly resolved when you take them out of the recruitment maneuver. So we're going to give this, and we're going to give no breaths delivered during that time. The reason we're not going to stack breaths on top of it is then you're into lung injury standpoint. You don't want to cause a pneumo in one of these patients. The last bullet point here is just saying that if you read up on people calling recruitment, saying we did this recruitment maneuver, the water's gotten muddied a little bit because now people are using higher PEEPs that aren't this high, but then they're putting pressure control breaths on top of it in some cases. So they're doing different things that they're calling recruitment maneuvers, but from a purest sense, they call it a recruitment maneuver is a sustained pressure of 30 or 40 for 30 to 40 seconds. How many of you do that in your practice? I think I see about the same number of hands as proning. So recruitment maneuvers, what we think about is when we do recruitment maneuvers, there's a variety of things that can happen, or the response can be very, very dramatic or not so dramatic. So what are some of the things that cause variability in whether the patient has a response to recruitment maneuvers? The patient may have stuff to do with the disease, the syndrome that they currently have. So if they have focal versus non-focal processes, early versus late ARDS is very different. Severe versus moderate ARDS. What's the recruitability? And we already said there's that line blurred extrapulmonary versus pulmonary. So their ARDS could be a cause for variable response to recruitment maneuvers. The type of recruitment maneuver you do, like I said, they're muddy in the waters. How high you go on the pressures, how long you hold that pressure out, or if you do some kind of thing that's a little modification of it. And post-recruitment maneuver strategy. So, like I said, just to get the lung open is nice for that time when that SAT hits 100 and the patient, you're like, wow, this is great. But if you don't do anything post-recruitment maneuver, and usually that's either put them on a strategy that's going to recruit them, like APRV, or pressure control with a long I time and a half-decent amount of PEEP, or even if it's just volume control and you're going to add PEEP to it. So the post-recruitment maneuver strategy is a very important part, and you'll see some of those things in a few slides. So some of the things that make you think, do we do recruitment maneuvers or not? Because if I'm going to put subject a patient to 30 to 40 centimeters of water pressure for that close to a minute time period, if something bad happens, I could have a pneumothorax. I could compromise the cardiac output, their oxygen delivery. I could overdistend good lung and hurt that during that recruitment maneuver. But then on the other hand, if I do the recruitment maneuver, the other side of it is I'm going to recruit their alveoli, I'm going to increase their oxygenation, give them a little more buffer, I can wean their FiO2, maybe wean some other settings, and I might ultimately reduce the ventilator-induced lung injury. So you've got this balance, and you really have to get to the point where you say, okay, the benefits outweigh the potential downsides for me to do a recruitment maneuver. So usually that's that sickest quartile of patients in ARDS. So got a few different studies that look at recruitment maneuvers. There's a lot out there. Again, in the scope of an hour here, it's really difficult to cover everything that you want to cover. But this looks at, and this is a very complicated study, this looks at 3 mechanisms of recruitment maneuvers and 3 types of lung injury. And very quickly, I'm going to focus really on one type of lung injury. They had ventilator-induced lung injury as one of the things. And this is in animals. This is a fairly long study with animals where they injure the animal with a ventilator-induced lung injury. And they do either, in this representation, it's a sustained, sort of a by-the-books recruitment maneuver. So they do that 30 for 30, 40 for 40. Or they do a modification where they're kind of inching up the PEEP and the PIP over time, and then they kind of go back down over. So this is sort of a schematic of that. Or they put the patient on pressure control ventilation with a higher PEEP level at that point. So they use pressure control ventilation as a recruitment strategy for this patient. Now, what do they see? And then they used multiple PEEP levels for after that recruitment technique to see which would oxygenate the patient best and longest. And I picked out 2. These are both on their model of ventilator-induced lung injury, which I think is probably one that we're most interested in as therapists. And they ended the patient with either 12 a PEEP to see how it lasted or 16 a PEEP, so 2 higher levels of PEEP. And in reality, the one that gave the highest oxygenation with the recruitment maneuver and then maintained it after the recruitment maneuver in both PEEP at 12 and even more so in PEEP at 16 was pressure control ventilation. So in this study, they actually showed that if you use pressure control with appropriate as a recruitment maneuver, and at the end of it you set PEEP properly, you're going to get a better and longer lasting effect with oxygenation than if you do the standard sustained recruitment maneuver that we just talked about. So I think it's very, very interesting stuff. Here's another one that did, again, another variation of this. They had alveolar recruitment maneuvers, and they were looking at, they looked at a couple different combinations. They basically, in the schematic here, they looked at doing a recruitment maneuver, and at the end of the maneuver in the schematic here, it says they increased the PEEP. So they did that, they put the PEEP up after that maneuver, or they just turned the PEEP up to see what happened, or they just did the recruitment maneuver but kept the same PEEP after the fact, okay? And they did that in about 50 patients, spread through the different groups. And what they found is, oxygenation-wise, the best and lasting effect was, as you would have guessed, you recruit them. They did an alveolar recruitment maneuver. That's what ARM stands for here that I put in. They did the recruitment maneuver plus the PEEP increase, and they get the longer lasting effect. And look at this. For anyone out there who ever tries a recruitment maneuver, but then the doc won't go for higher PEEP afterwards, the recruitment maneuver gave better oxygenation. It gave you that, patient looks better. And they went right back to, right down to where they were before, basically. So if you're going to do a recruitment maneuver, you really need to add the PEEP after it to PEEP the patient properly. That same study looked at pulmonary. It dissected out the pulmonary and the extrapulmonary ARDS, and they found that the extrapulmonary ARDS, as you might guess, were oxygenating worse before the maneuver, and they were oxygenating best after the recruitment. So here again is one more piece of evidence, I guess you could say, that these pulmonary versus extrapulmonary do act differently, and extrapulmonary seems to be more recruitable. You can recruit it better and increase your oxygenation better with that extrapulmonary, with an extrapulmonary ARDS versus pulmonary ARDS. This study here, I know it's a very busy slide, and in the interest of time, I'm just going to say they did a very similar thing, but they really focused on the mechanics, and they found that after a recruitment maneuver, they found that pulmonary ARDS did not really change the compliance, but extrapulmonary ARDS, the compliance got better. So basically, you do recruitment maneuvers on the patient, and the compliance got better on patients who had extrapulmonary ARDS. Again, another study saying that you've got a different response if the ARDS was extrapulmonary. And I think, so recruitment maneuvers, this is systematic review. So there have been a lot of studies out there on different types of recruitment maneuvers, and even very stringent, just the one sustained type pressure. that I opened up, saying that's sort of the traditional recruitment maneuver. And when you do the systematic review, they found 40 studies, over 1,000 patients, and what they found is similar to what I've told you. They found that oxygenation significantly increases. Side effects, their major side effects were infrequent, so where anything really bad happened. But desaturation and hypotension were common. They're relieved once you're done the recruitment maneuver, but they are common. So you are subjecting the patient to potential side effects. And what they really recommend, they recommend it for the most life-threatening patients. And I'll just be like a broken record and say probably the worst quartile of patients. So whatever you have in your mind for those ARDS patients in your institution, probably the sickest of the sick will benefit from recruitment maneuvers. This is just some data they had in there, which really shows the same thing as we showed, so I'm not going to take much time. Oxygenation pre and post recruitment maneuver, you get that increase in oxygenation with recruitment maneuvers. This is a New England Journal article that is about lung recruitment in patients with ARDS, and what they really found is it's sort of interesting. They really looked at, like, if you can recruit the patient's lungs. Will PEEP recruit patients' lungs? And what they really found was they found that the amount of potentially recruitable lung is extremely variable. I think we knew that, but beyond a reasonable doubt, the amount of recruitable lung varies greatly among patients and is associated with PEEP response. So there is a PEEP response effect where if you can have some patients who are really do not respond to PEEP very much at all, and then you have patients that respond very greatly to, and this is going to be low, one of these, but they just show an image of a patient who's very low percentage of potentially recruitable lung disease, and at 45 centimeters of water pressure between 5 and 45, you don't see much of a difference, and you have a patient with lots of consolidation who's highly recruitable, and you see the dramatic difference in that CAT scan slice of how much lung can be recruited. So when you're talking about ARDS patients, some patients, it's variable whether you're going to have a lot of recruitment potential or not. So you kind of have to test that if you're into wanting to recruit these patients' lungs. I wanted to mention this because I think it's interesting. The Surviving Sepsis campaign came out with a revision in 2008, and many of you may or may not have looked at this or know about it. I know we reviewed this with our critical care docs, but the interesting thing, and you can't read this probably from where you're at, but it says PEEP should be set to avoid extensive lung collapse at end expiration, and they have a 1C level of evidence for that in their guidelines. So the sepsis guidelines say that you should use PEEP to avoid lung collapse. And within the body of the article, it says, and we're going to get into a couple of these concepts, whichever indicator, we're going to talk about which indicator you look at for lung recruitment, compliance of the lungs or oxygenation. So do you watch the SAT or do you watch the compliance of the patient when you're recruiting the lung? You can look at either of those things. We'll talk about those. But it says whichever the indicator, compliance or oxygenation, recruitment maneuvers are reasonable to employ in the process of PEEP selection. So basically you have the Surviving Sepsis campaign, which is a very powerful document that is saying that we should be recruiting these patients when they are in need of recruitment. So the next technique, static, and I lump these together, static and then a low flow or slow flow pressure volume loop. So what's this have to do with recruitment? Well, it's going to be a technique that helps you identify where are you recruiting lung, where are you overdistended, and where are you collapsing. There are a couple different methods before I sort of show you some graphics here. There's a super syringe method, and what that is, that's sort of the gold standard, which is a nightmare to do at a bedside, is that you literally would have a large syringe that you know increments of 50 or 100 mLs on, and you have a pressure manometer, and you take this patient, an ARDS patient who's sick in your ICU, off the vent, and you start putting in you let them exhale all the way to nothing, and you start putting in increments of 50 or 100 mLs at a time, and you also take note of what their pressure does on the manometer, and you map that up to whatever pressure you're comfortable going to or whatever volume you're comfortable going to, and then you map out a loop on paper or however you want to graph it out, and you can see this is how they first started doing the lower P-flex and upper P-flex points that we'll mention in a second. Now, Then we realized that if you use the ventilator, you can slow the flow of the ventilator down slow enough, or the theory was if you could slow the flow down low enough, you could do a maneuver on the ventilator without disconnecting them. It could be more automated, and then they could go back to their normal ventilation after the fact. And so I'll mention that, and that is another method that would be sort of a slow flow or low flow pressure volume loop. And then different ventilator companies, the ones back here, have that on it. As I'm guessing they have that option on here. So I don't know if you played with it, and then there are other brands that have it, and they have their proprietary names on it, but they have a way of doing a slow flow pressure volume loop to determine the lower and upper P flexes. With this, the key thing is the patient needs to be not active. So you have to take that patient, you have to take their drive to breathe out, because you want them to just passively sit there and let you inflate their lung, essentially, to see where their lower and upper P flexes are. So what do these things look like? Well, this is a very simplified version of a super syringe method where as you add volume and pressure, you map it out. And as you map this out, this would be indicative. You have the curve here, and you heard other lectures, I think Dr. Bashi talked about this, ventilating at the sweet spot or where they're most compliant. The most compliant part of the curve is where it's pointing upward farthest on this. And then where you're least compliant is where it's kind of like laying over. So the top lays over and the bottom lays over. Those are very non-compliant areas. So the top, where this thing inflects from compliant to non-compliant, that's your upper inflection point. And the inflection from non-compliant down here to compliant, that's your lower inflection point. So what you want to do is you want to set your PEEP. What experts would say is above the inflection point is where you should recruit the lung, because down here you're de-recruited and you have to open up alveoli to get to this point. So that's sort of a schematic of a super syringe method. This is sort of one that is live, a computer done, and you can almost see the jaggedness of them putting the volume in and then letting it sit for a second, then putting the next set of volume in, and you can map out on this sort of lower inflection points and upper inflection points after you massage the data just a little bit. What I want to come back to is not a lot of people do that, and they do it for research. But what can we do every day for these patients if you're interested in the pressure volume curve and the P flexes? Well, the devices that do this, they can do it in the range of less than 9 liters of flow. And this is the study that they performed to show what flow for low flow on a vent would work. So one of these lines here is actually the super syringe method, and the other one is the ventilator doing the maneuver at 3 liters per minute. What's the rationale for that? The rationale is 3 liters a minute, you are seeing the compliance of the lungs. There's no resistive component. The higher you go in the flow, the more you see resistance. They also did 9 liters per minute, and that's this line here. And what they say is 9 liters per minute, you start seeing a little interference because of the resistance. It shifts it to the right, but probably not to the point where even at 9 liters, you could probably make an educated decision about a lower inflection point for where to put your PEEP, and then if there was an upper inflection point. But again, this is something that's kind of cool. It's come to bedside. It's FDA approved by several ventilator companies, and they have this to bring to bedside. And it's been a long time in coming. You see, this was out in 1999, this article that identified that 3 liters is probably a good liter flow for that. Now, I want to hit a topic that's called open lung ventilation, and I'm using that term sort of loosely, but here's what I'm going to wrap around it is that there are some people out there who have done studies where they've mixed and matched methods that I've already talked about. They throw in recruitment maneuvers with differences in PEEP, maybe PEEP the decremental PEEP trials, and then what their goal is to manage the patient with open lungs, similar to what Dr. Bashi talked about with APRV. So some of these studies go back a little ways, and it's kind of interesting that we didn't learn from these and kind of expand on them. This is back in 1995. Dr. Amato's group published this. It's called The Beneficial Effects of the Open Lung Approach. And I know it's very small. The new approach was small tidal volume versus large tidal volume, just like ARDSNet. This is 5 years before ARDSNet. And they used pressure control, and a lot of it was pressure control, PCI-RV. It was inverse ratio pressure control. But it was all pressure ventilation, and they kept the PIPs low. They did recruitment maneuvers. They did P-flex points on the patient to figure out where to set the PEEP, and they set the PEEP at above the lower P-flex. So they basically combined a lot of that stuff that we talked about all together in one. And what did they find? Again, it's a small study. It was published in the Blue Journal. And what they found is that if you looked at, I'm just going to show you a few different values. So this is total PEEP. This is that newer open lung approach. PEEP was much higher than conventional approach. So PEEP was much higher. If you look at peak and plateau pressures, I don't know why that red circle's there. I'm not sure why, but the new approach had lower peak and plateau pressures than the conventional group. And the oxygenation was much, much better in that new approach, that open lung approach. And that's why the circle's there. Because then they found a significant difference in mortality in these patients. And this, unlike the ARDSNet, showed better oxygenation and better outcomes, whereas ARDSNet didn't have better oxygenation, it had better outcomes with the protective group. When you combined all these things in a small study of ARDS patients, they found a difference in mortality, 46% versus 67%. There's higher mortality rates back in the 90s that Dr. Abashi made reference to. So, and then that group did a larger study, and it was large enough and significant enough that it actually was published in the New England Journal of Medicine. And this, they didn't call it open lung ventilation, but it was really the same strategy. They used low tidal volumes, they used pressure control ventilation, pressure volume curves with recruitment maneuvers, higher PEEP above P-flex points, that kind of thing. And what they also got was they got a difference in mortality, 71% versus 38%. This was sick, 71%, but these patients had nearly, the ARDS is less than 200 for PF ratios. These patients were down near 100. So they were the sickest of the sick, and they saw a difference in mortality rate, and this is just a survival curve that just shows that difference in mortality rate. So again, putting all those strategies together back in the, and that was actually 2 years then before ARDSNet was published. Now, this is another study in 2009 that what they did was they took and they wanted to see if you put these strategies together, you do a pressure volume loop to identify PEEP flexes, and you do a recruitment strategy, and then you do a decremental PEEP titration. What do you use to find out what PEEP to stay on? So you do the recruitment strategy, and then you identify, you look at something. Like I said, you could look at the SAT, you could look at lung mechanics. What do you look at to determine what PEEP to stay on for these? And really what they found, and this is a very sort of ugly slide here, but what this is compliance. This is really blood gas type values. This is the shunt of the patient. This is lower P-flex. And really what this whole slide gets at, and this is my point with this slide, is no matter what you looked at to say, where do I set my PEEP after I open up the lung, almost all these things came out to around the same PEEP that you'd select to keep the lung open. So one of the summary points is you can look at compliance, you can look at blood gas values, you can look at P-flex. You're probably going to pick a fairly similar value to pick if you're doing decremental PEEP titrations. In the interest of time, I'm not going to hit esophageal guided settings. This is a whole lecture in and of itself. But just to say that you can use the esophageal catheter to help you set not just over distension to not over distend, but also to set proper PEEP levels to protect or to recruit the lung and that kind of thing. But I'm going to move through that one in the interest of time and look at this one. Now this is kind of an interesting study here. This is the reversibility of lung collapse for hypoxemia, and this is early ARDS. And what this study did, they took 26 ARDS patients and they tried their best to get the patients to recruit. And they found that they could recruit, fully recruit lungs at a plat of 40, but some patients took up to 60 of pressure to fully recruit. What was full recruitment? You see the lung images here. Full recruitment could take upwards of 60 of pressure to do it. But what they found is that you actually can get full recruitment in most patients if you really try hard enough. Again, it's not an outcome study. They don't have outcomes on that. And there were transient side effects. Obviously, you put a patient at 60 of pressure for a while, you're going to hurt their hemodynamics. That got out of order, but we're not going to do the esophageal pressure one anyway. I'm not sure how that happened. So let me move a little bit into monitoring, and then we'll end this discussion here. So we've already talked a little bit about monitoring because we've had things that people were monitoring with the recruitment maneuvers. So what are our options with monitoring? Well, they're going to sound archaic because in reality they are. Blood gases and pulse oximetry. What are the problems with that? They're global. What do I mean? You find out how's the patient oxygenating. You don't tell, the pulse ox doesn't tell you if they're recruited. It doesn't care if they're overdistended, recruited, or anything. It's also, if it's blood gases, is it timely? How many blood gases do you want to do? And also, is oxygenation really relevant to outcomes? And I think you can look at studies and say, no, oxygenation probably is not necessarily relevant to outcomes. So looking at blood gases and pulse oximetry, I'm probably just like you where there are times when we find ourselves, and I always say the blue number, we're standing there trying to do something to the vent to make the blue number look better. Our pulse ox is blue on our monitors at our institution. And really, we should question when we're doing that. How about radiologic imaging? And you've seen x-rays and CAT scans in all these lectures. You can look at x-rays. They're not timely. They're at one point in time. They're not live. And they're 2D. You don't really see that whole, for us to show you ARDS, we usually have to show a CAT scan slice. And so that brings us to CAT scans. They're also not timely. All these things subject the patient to radiation. They're not live. You don't see the patient breathe. You just see what's expanded or not expanded. And most people have to transport the patient to CAT scan. Not a lot of chest, you can't do a lot of chest CAT scan or CAT scans right in ICU. Usually they're head CAT scanners. I think it exists, but I haven't seen or heard of a lot of people having that. Ventilator mechanics. Problem with those? They're not global. They're global, they're not regional, just like oxygenation. You can see overall good compliance, bad compliance, but you don't know if something's recruited, de-recruited, or overdistended. Difficult to interpret. I mean, we had a thing here today that to go over event graphics, but still graphics, unfortunately, are a little difficult to interpret. They're variable. They're breath to breath, mode to mode. You make changes. You'd have no idea if you change recruitment from a vent standpoint necessarily. Stress index. I think Jeff mentioned that in there. You can look at stress index, and that may be easy to obtain, and also maybe of some value. I think a little more on the, I mentioned the mechanics. So mechanics, if you use the ventilator mechanics in your decremental PEEP trial, so this is mixing decremental PEEP trial with looking at the compliance of the patient. Look at that nice bell curve there. So you'd say, well, right in here is a sweet spot where most of these patients are most compliant on their decremental PEEP trial, and guess what? It's right around 15 a PEEP. It's also at the same point, and this is a busy slide, it's at the same point where the oxygenation's good but just starting to get bad, just starting to turn downward, and where shunt is just starting to turn upward on the bottom of the slide, and where non-aerated alveoli are really starting to open up. So what this shows is that if you use that compliance, the dynamic compliance of the patient, you might be in the ballpark for some sort of a sweet spot for ventilation where you're being gentle but you're recruiting the lung. Stress index, and Jeff put this up. I won't say much more about this except for the fact that if you'll know if you're overdistending the patient, if your volume control ventilation graphic has that curve to it upwards, you need to watch out that you're not overdistending. And what you may find is if you recruit the patient, it may turn more to this where you are not stressing the lung as much because you've recruited the lung and now it's more compliant. So that's all I'll say about stress index. Ultrasound, this is kind of interesting. Takes specialized training. You get a very limited view, labor intense, but I thought interesting nonetheless. So what are we talking about? Looking for those areas that are bad in ARDS. They felt in this study that they had experts that could see if you could look for the lung that's not recruited, and then you could do maneuvers to recruit it and watch it on ultrasound. Kind of an interesting concept. And very limited because you can only see so much of the lung with ultrasound without other things kind of being in the way. But what they did find is that if the ultrasound person said, yeah, you're recruited, the oxygenation got better with the maneuvers they did when the ultrasound person said it looked better. And also the non-aerated lung, when they said, yeah, there's less atelectasis, they found that there was less atelectasis as you went up on PEEP. So the point being, they were able to look at PEEP and monitor it with ultrasound and seeing if they were recruiting the lung tissue of the patient. Vibrational response, it's vibrational response imaging. Looks kind of interesting. I don't know if anyone's seen this. They're using it. There's niches for this. This is probably going to be real difficult to put in for ARDS patients, ICU patients, because look at that contraption. But interesting nonetheless, it's microphones, and it listens to where you're ventilating. And you literally, like in this case here, in volume AC, you get this image, and this particular patient, the patient's breathing, you know, a little deeper, you get a little more, I guess you could call it recruitment, pressure control, patient spontaneously breathing on PSV, you can see. So it's sort of an image, and these are live images on this. But again, I'm not sure that it's certainly not prime time for an ICU type patient and all the stuff that's hanging on them. That's a heck of a thing. Plus, it's really just up and down the back. It's really two-dimensional. It's sort of like an image of their back, essentially. One of the most interesting things that I like, and then I'll wrap this up real quick, is something that we got the chance to use is electrical impedance tomography. We were able to get a sort of a view of this with a prototype device before it's been FDA approved. And what it is it's actually a chest band that goes around a patient. We accidentally left it on for an x-ray, so I think that's kind of cool there to show you where it goes around, because we're really aiming to take it off. We don't want to obstruct any imaging there. But that's what it looks like sort of on the outside of the patient. And what I do want to say is, don't get mixed up in a couple images I'm going to show you that it's a chest x-ray. It's really a CAT scan slice. So think of it as it's a band going around the patient, and you're getting sort of a CAT scan slice of right around where that band is on that person's chest. Okay, so you're getting a CAT scan slice. It uses electrode belts to give you basically a functional tomograph. It's using impedance technology to give you a functional tomograph of where flow is moving and where it's not moving. And so if it's not you have atelectasis, you have no flow movement. Okay, so you can see de-recruited areas. So just to give you a feel for this is a patient that was on, I think this is the only thing left that was APRV, but I think it's really cool. Patients on APRV, you can clearly see the releases here. And this person has, again, don't think of it as an x-ray, even though I have it next to an x-ray. This patient had a pleural effusion and atelectasis here, and you can see that's an area where if we took a CAT scan, this person would not have lung opened up in that area, and they are de-recruited in that area. The other thing I think is interesting when you talk about that dwell time and the convective forces, this to me showed me how well APRV, the heart is mixing that gas around. The heart is mixing the gas and making each breath so much more efficient in APRV there with that long dwell time. Just to give you a couple of more flavors, we had this person here. This is their CAT scan image. So they had some atelectasis down in this region here. And in fact, this CAT scan was a different day than what we were monitoring. But what we had was you had a person on volume control ventilation. This was on volume control ventilation, and they didn't look all that perky, and we wanted to change them to pressure control, and we happened to have the EIT device on them. And I don't know if you can focus here. This area here is very sluggish to inflate. And over here on pressure control, really same PEEP, is inflating better. And also we get better inflation in this region than we really have over here as well. So you get, what we saw in this case was we had better gas distribution. We were able to identify better gas distribution with pressure control versus volume control. And this was one really kind of cool case that we caught. Cut to the chase, in the interest of time, we placed a patient on a spontaneous breathing trial, and this is what they look like. Come on, run. It's going to do that to me. So we see really nice ventilation throughout. They were desaturating about an hour into their spontaneous breathing trial, and let's take a look at what we lost. Patient de-recruited something. Patient de-recruited this whole quadrant of their lung. Again, think of it, I know I have an x-ray there, but think of it as a CAT scan. They de-recruited that whole dependent area there. And the patient then, so you remember what that is, I'm not going to start, this is that same video. This was after they realized that they de-recruited the patient. They went up to 12 a PEEP to re-recruit them, and you can see that area there nicely re-recruited on 12 a PEEP, and thus the patient was deemed not ready to come off the vent. But the interesting thing is, how often do you guys have someone that fails a spontaneous breathing trial? Who knows what it is? In this case, we know exactly what it was. The patient de-recruited their lung. So we can see that recruitment right on there with the electrical impedance tomography. And this is just another one to show you the imaging. We happen to have a CAT scan the same day of the imaging of this. So if you see this here, we've got consolidation of here. We've got a little ventilation here, and then this lung looks like it's ventilating. And in reality, we have that ventilation here and some up in the upper quadrant, but definitely no ventilation on EIT down where all this is happening. So again, using that imaging live right at bedside, just a chest belt on the patient to be able to monitor their whether they were de-recruited or not. I'm going to go past that one in the interest of time and just get to the summary here. The summary, what I would say is, from a technique standpoint, you have recruitment maneuvers, you have decremental PEEP trials. They've shown some promise in maintaining recruitment. You kind of have to use them in tandem, pick the right PEEP. Slow flow pressure volume curves, they're definitely feasible bedside. You need a ventilator that can do it, because that's just the easiest, nicest way to do that. Open lung method, I would keep it in your mind. Open lung method is a really nice method where you're using multiple of these things to get the lung open and then gently ventilating the lung once it's open. And small studies have shown very good outcomes with that. From a monitoring standpoint, as I mentioned very quickly, current methods of monitoring are they're either not timely, they're not feasible, they're not live. They're really not live at bedside, and most of them are global. You don't know what's going on regionally in the lungs. So, and as I mentioned there at the end, newer technologies are on the way, and hoping that they can get to bedside soon. And I think that's it.